a good resource. I think that that leads us in a bit to there's several questions about specific trials or specific drugs that patients in our community have been curious about.
Mhm.
I'd like to start with SERDs.
Yeah.
You just mentioned them, and
Mhm.
I think there's just an overall curiosity about how this fits in with the aromatase inhibitors and tamoxifen and like those class of endocrine therapies that we might be more familiar with, and then how those are currently being used in the metastatic setting. And I believe there's trials looking at them in the early stage setting.
Absolutely. So SERDs stand for selective estrogen receptor degrader. So think about it this way: anastrozole or aromatase inhibitor, so letrozole, exemestane, what they do is they block production of estrogen in the body. Now, you have to be in menopause to be on an aromatase inhibitor because it blocks estrogen production everywhere but the ovaries. But they put people into a very low estrogen state because they're essentially depleting you of estrogen. So, this is where we run into a lot of the side effects that people experience: the hot flashes, vaginal dryness, joint pain, cognitive function, and so bone health issues and so forth. Tamoxifen doesn't do that. It doesn't block estrogen production, but it takes the estrogen that's already in your body and doesn't allow it to bind to a breast cancer cell that has the estrogen receptor. SERDs are different. They're really looking at degrading the estrogen receptor. So they're not getting rid of the level of estrogen in your body, but they're degrading the receptor so that the estrogen that's floating around can't find a home in the receptor. So if you think of estrogen and the estrogen receptor kind of like a key in a lock situation, there's no lock. So there's nothing for that key to it just kind of floats around. A SERD that we're all familiar with is Faslodex or fulvestrant, which we use in metastatic disease. But these are kind of next generation SERDs. A lot of them are oral medications, and they're being studied both in metastatic disease, where we already have an approval with a SERD called elacestrant or Orserdu, which is approved for patients with metastatic disease that are hormone receptor positive that have an ESR1 mutation. That mutation kind of can tell us that they maybe develop some resistance to an aromatase inhibitor, and we can switch to the elacestrant. There are a number of SERDs being looked at for early stage breast cancer to see, are they better than the aromatase inhibitors, and also are they less toxic? Do they have less side effects? Those trials are going to take some time. We're not looking at 6 to 9 months here. I mean, I think the SERDs in early stage disease is going to be several years. But there's camizestrant, there's illuminesestrant. I mean, there's a lot of them. And this is a great example of what you were talking with Suzanne. Well, maybe you didn't get onto the camizestrant study, but you can get onto, the other SERD study. And I think, I've been getting a lot of questions recently. Well, which SERD is better and which study should I do? And we don't know. I mean, that's clinical trials are attempting to answer this question. We don't know what is going to pan itself out. So lots happening. There's a lot of targets targeting the estrogen receptor kind of in a novel way. And hopefully that will improve side effects as well.
Okay. Um, so this question, I think, goes along with this perfectly. I'm trying to make sure I understand it. With the ESR1 mutation, and then you said that the SERD or SERDU is the one that's approved in the metastatic setting right now, could be indicated in that situation. Is that different than a hormone positive breast cancer losing its estrogen um, signaling when it progresses?
That's a little bit different.
Okay.
What can happen is tumors can change or they can mutate. And so the receptors that they had no longer, they're different. So sometimes a cancer really fed on estrogen and it starts to lose that estrogen receptor and it no longer feeds on estrogen. So you can think of it again, the keys or the locks have changed, right? So the key that you were fitting in, well, the lock is different now, so your key doesn't fit into that lock. So that's why a lot of times when someone has had early stage breast cancer and they've developed a recurrence or progression, we actually will rebiopsy it because we want to make sure that these markers, these receptors haven't changed so that we're targeting, we know exactly what we're targeting. So with ESR1, that's a mutation the tumor can acquire, but it hasn't changed its hormone receptor status. But this kind of falls again into this whole category of biomarkers and molecular testing. And really, all breast cancers are so unique. And so as we think about treatment, we're making sure, okay, we've got our ER, we've got our PR, we've got HER2. Now we also have in metastatic disease, we're looking for ESR1 and PIK3CA and AKT and PTEN and all of these things. And that's looking at mutations and changes in the tumor. Some patients inherit a mutation like the BRCA mutation that's in their blood, germline mutation that's in all of their DNA. And we do have drugs to target that as well. So when we think about genetic testing, we're thinking, individual germline, something that's in all our cells, but then also tumor testing.
Yes, for everybody listening, because I know that that was a lot. We did a previous webinar. If you look in our app or on the website about the difference in genetic and genomic testing and how that can match up to different therapy options. And I know that that's what Dr. Toplinsky was just getting at there. But I also know it can be from firsthand knowledge really overwhelming and
It is.
confusing.
I mean, it's a whole other topic.
Yes.
There's just so much, and that's just kind of highlights, right, the complexities of treating breast cancer nowadays.
Yes, 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 the complexities, but also just the opportunity and the hope in
Yeah.
precision medicine and having so many things available to us. Uh, there was the question that came in. Let me see if you have something to add to this, but she wanted to know if there was anything in the works specifically for an ATM mutation.
Well, I mean, nothing that I'm aware of the top of my head, but there are so many um drug discovery and preclinical and clinical research ongoing that there may be something in the works. I think obviously everyone who has a genetic mutation, right? With BRCA, if you have a BRCA mutation, we can give Lynparza. And so of course for other mutations, we're thinking, well, what can we give, right? And there is research ongoing, but nothing at this time for ATM or CHEK2 specifically to target that. But that does not mean that there won't be something in the future.